Afternoon, everybody. Thank you so much for joining us today here at Healthmonics as we present to you the 2026 final rule. It's going to go over what's ahead for the MIPS, APP, and the newly developed ASM program. I am joined today for Throwback Thursday with my old buddy, Philip Spence. Welcome, Phil.
Hey everyone, glad to be here. Standing for
Glad,
Lauren, who couldn't make it
glad
today.
Glad to have you. Glad to have you on. Thank you very much. Phil and I will be passing the baton back and forth as we dive into what is a very detailed webinar that gives you, the listener, the opportunity to understand our highlights, but also have the resource available to you after the call so that you can see some of the changes that are in more detail on the slides. We, as always, are available for questions. There is a link on the right-hand side of your screen, the little question mark. You could go in there and type your questions in. I can't promise you that we will get to every question as this is a very detailed presentation, but I can tell you that by the end of next week, all of your questions shall be answered through email, if not from a reach out from someone here at HealthMonix. We also have the handout section that's available. And later on this afternoon, I will send everyone a copy of the webinar slides as well as a link to view the webinar itself. Today, we're going to cover changes to traditional MIPS, some of the enhancements to MVPs, what's new with the APP, so for the ACO reporters, we'll have some information about that, as well as what's not on here is the introduction of a finalized rule that the ASM program that was proposed in the 2026 proposal rule earlier this year has been finalized. So CMS had some final rule objectives. First off is reinforcement, strengthening the MIPS value pathway framework. I think you're going to see how they are guiding everyone towards MVPs and are being very detailed in when traditional MIPS is planning to be done, as well as when MVPs are going to become mandatory. Simplifying, so reducing administrative burden and enhancing usability. I think what you'll see some here are some changes that align some of the programs across all of CMS quality and programs to utilize the same measures, to utilize the same scoring and frequency of submission and so forth. And that lines up with the align part, and then elevate, which is reward clinicians providing high value of care. So a couple interesting numbers I found in the almost 3,000 page final rule this year. 94.02% of active participants in MIPS in 2024. So that includes the providers and clinicians that were eligible. 94% of them were active participants. That equates to a little less than 500,000 participants in the MIPS program in 2024. And what I found interesting is 87.37% of those participants received a positive payment adjustment. So just less than 13% of clinicians either received a neutral payment or a negative adjustment to their MIPS numbers. That does not leave a lot of money in the pot to pay those winners because it is a balanced budget where anybody that's paying into the MIPS program is paying the people that perform well. So that's why we saw very low numbers in the for performance for 2024 and those adjustments in 26. All right, let's dig into some overall MIPS type information here. Everything's remaining the same that you see on this board. The split between the categories of improvement activities, promoting interoperability, cost, and quality will stay the same. Same with all of the abilities to have exemptions for things, as well as the small practices, and everything is staying exactly the same. There hasn't been changed to that at all. Eligibility is still 90,000 in Medicare Part B charges and 200 Medicare Part B patients and covered professional services to make you fully need to participate in MIPS. If you have one of those three, you can opt in. If you have none of those three, you can report, but it will just be test reports. You actually don't get a score adjustment at all. So the minimum to avoid the penalty, they're keeping it exactly the same. Not only are they keeping it the same, they are actually saying that it's going to be the same all the way through the 2028 program year. So for the next 3 years, it will be exactly the same. They are doing this so that they can provide some stability while we move over into the MVPs. One of the biggest changes in this rule for 2026, it was all in the proposed rule, but a lot of what you'll see through this presentation is that many things stayed the same. One of the big changes, though, was the removal of health equity from the entire final rule and the entire program altogether. You guys can read the what does health equity mean, but the things that CMS has done is in 23, this was actually in the final rule of this year, it stated that they added the health equity into its definition of high priority measure due to significant persistent inequity, in health outcomes. But in this final rule, due to what they're saying was confusion over what health equity means and how a practitioner can work with it, as well as the COVID pandemic being over and overall changes to healthcare and how they need to address all beneficiaries are the reasons they're removing not only just the name health equity from the rule, they are also removing quality measures 487 for screening for social drivers of health, as well as 498 connection to community service provider. They're removing 6 improvement activities that are aligned with health equity, and they are also removing the health equity bonus as part of ACO scoring in 2026. And some of these will go into a little more detail as we go down through this presentation. So we're going to jump straight into MIPS quality here. Once again, data completeness staying exactly the same as it has for a number of years now. I can't even remember when the last time it was below 75. I think it was 70 3 or 4 years ago, and then slowly increased before then. CMS wants to increase the benchmark in the future, but they're going to keep it at 75% all the way through the 2028 program year. Once again, is aligning to their let's not make many changes in traditional MIPS while we go through the transition to MVPs. They're adding 5 new MIPS measures, removing 10 MIPS measures, and one of my favorite words, substantive changes to 31 measures. That word is interesting because some of them are like adding a word to the measure, but some are some pretty significant changes. So here are the 5 new quality measures for 2026. I'm not going to go through all of them, but what I find very interesting for these measures is that CMS states what you'll see on the next page, that they are getting rid of as many process measures as they can. However, and same with the QCDR, so QCDR measures, which are the specialty measure sets, they're not allowing process measures in. But of the 5 new measures that they're introducing for 2026, 3 of them are process measures. So they're kind of saying we're getting rid of all the process and now we're adding all the process. So here, these are the measures that are going to be removed in 2026, each of them with their own reasons here. End of a topped out life cycle, extremely topped out. You could see the average performance for 290, 322, 419, and 424 are all in, less than 2% from the top or bottom of their performance threshold. So there's no real difference between different clinicians on these measures, and therefore they are removing them. 443, the measure steward is no longer maintaining the quality measure. And then what you'll see from 487, 498, and 508 is that CMS is saying they're removing these due to them being process measures that no longer considered a high priority measure. And it aligns with removing removal from them from other CMS programs. So here are the substantive changes, and this is what I was saying that, there's a lot of information here. I'm not going to go over everything, but to point out a number of things that could be beneficial or to understand a little bit more is, if you really want to take a look at these and understand, there are some changes this year. I saw actually a lot where the ECQM changed in one way and the MIPS CQM changed in another, like measure 143. The MIPS CQM is adding patient on oral chemotherapy, and then excuse me, and the ECQM is removing the telehealth from language. I'm hearing some people may be having issues seeing the documentation on my screen. If others are having it, please let me know, and we'll restart this. But I'm not seeing the issues from my side. All right. Thank you. So on the next page here, what you'll see once again is that they're sometimes they're revising things. They're adding telehealth is being added to a lot of measures as is becoming more prominent out there. And sometimes you'll see in these, it's just updating timelines on the measures. On the last page here, I want to point out that measures 112 and 113, which are currently MVP only for 113, and for 112, 112, it's for both MVP reporting as well as the ACO reporting. They are revising the age range for ECQM for breast cancer, which is a biggie. Never understood why it was very different from the CQM, but now they're aligned in 2026. Lastly, I definitely am not going to go over all of this. These are the specialty measure sets here for your viewing pleasure later, but you can see that the removal of those social determinants of health and COVID measures from every single one of these specialty measure sets across the board. And then you'll see, for instance, in family medicine, they added 3 measures. So anything you see there in that 500, 512, I think 511 through 516, are the new measures, and then you'll see randomly throughout this, some other measures were added to the specialty measure sets for this year. All right, so this is something that's actually come up in a couple of my meetings with our clients here, and it's really understanding the administrative claims measures. So I wanted to kind of go over what the administrative claims measures are and how they impact your MIPS scoring. So for traditional MIPS, you'll report your 6 measures, and then CMS will add these measures onto your scoring if you meet the case minimum and eligibility. So those last 2 columns there at the top, if you meet both of those, CMS will add them as a 7th, 8th, 9th, or 10th measure in your traditional MIPS scoring. There's nothing that you need to do. CMS delivers those results based on claims. So these are the quality measures that are automatically added. So what's changing in 2025? Similarly, actually, and this has gone back retroactively to 2025, similarly to what they did in the cost category, was that instead of making the average 5 points, which really, penalized the people that are meeting, the thresholds of, being in line with the rest of the nation. They are moving that up to be 7.5 points, so that everybody is based upon the standard deviation off of an average score of 7.5. That's really going to help people with scoring. They helped people in cost when they moved it that way. The reason they actually have decided to do this as well is because these measures normally score much lower than your traditional MIPS measures, because the traditional MIPS measures, there's a target for you to go get. And It's based on 2 years ago's information for most cases. So people have a target to go after. And if everybody scores above the target, everybody can score well in traditional MIPS. However, in these measures, saying that they are current year performance, someone will score a 1 and someone will score a 10, and then everybody else falls in between. And that was reducing people's score. So this increase, they're saying, will increase everybody's quality score by 1.46, or overall score by 1.46 to 1.96 points. Not bad. And that could be the difference between a penalty and an incentive. And it will increase the overall score 3.67. And now I'm going to pass, oh, one more, then I'm going to pass it over to Phil. So what does this mean to clinicians? No changes on how you're scored, no changes to the reporting thresholds, no changes on what categories you need to report on, and no changes on how you need to report. So not a ton of changes. Some of the things to keep an eye on: breast cancer screening measures, changing the age range for 112. If your EHRs aren't up to date with the new measure specs, which is very hard to keep up since CMS delivers them so late, just know that your population could increase once the new measure specs come out. 134, depression screening, they're adding pharmacological interventions that can really help you reduce those measures, reduce the not mets for those measures. And then they're getting rid of 10 measures, but the most important ones here are social determinants of health, connection to community health advisors, as well as the colonoscopy interval. Those are the most popular measures that they're removing. So finally, I'm going to pass it on over to Phil.
All right. Thanks, Mike. So next we're going to go into improvement activities, and somewhat similar to quality, we're not seeing any large changes in the performance category. The structure is staying the same. We are seeing the addition of improvement activities. So you can see at the top here, 3 improvement activities that have been added: improving detection of cognitive impairment in primary care, integrating oral health care and primary care, and patient safety and use of artificial intelligence. So these are new. They will be optional for selection. We also see an activity changed, one listed here within behavioral and mental health, which is receiving a name change and now requiring a comprehensive physical health screening. So that is not a whole lot of difference within the improvement activity category, but what we are seeing is, as is similar with quality, the removing of really any connection with health equity. So achieving health equity previously was a subcategory of improvement activities. That is being removed, along with what we'll see in a moment here, the associated activities, and the addition of advancing health and wellness as a subcategory for the performance category. Moving on, so the improvement activities that are being removed are those associated with health equity. So all of the subcategory activities under the subcategory for health equity are being removed. You can see the list here. If you have been participating in these, you'll want to look at other activities. And similarly to what Mike mentioned in the quality category, CMS provide rationale for removing these activities and really emphasizing that the demonstration of improvement of patient health was not there compared to other objectives, and that they don't reflect CMS's prioritization of measurable clinical outcomes and are now focusing on topics of prevention, nutrition, and well-being. So overall, not much change in improvement activities. So next we're moving on to the cost category. And with cost, we're seeing no changes to the measure inventory. As you can see here, there are 35 measures that are available for selection within 2026 reporting. These are the same 35 measures that have been available for 2025. So no change into which measures are going to be available for the new reporting year. But as we move on to this slide, here we are seeing a change in how new measures will be implemented moving forward for the cost category. So now we have the introduction of a 2-year delay for cost measure adoption. So what CMS is doing is saying when we do add new cost measures, of which there are none for 2026, they want to provide clinicians with the opportunity to understand and assess their performance in those cost measures before those measures impact their score. So the way that's going to work is that in year one of a newly added cost measure, clinicians will not be scored on that measure, but will be evaluated on that measure for feedback. So when we get into the second year of a cost measure, you'll be able to receive feedback from CMS that will allow you to make adjustments, changes, or assessments for different actions within your practice to best manage that cost measure. Also, in this subsequent year, you'll get feedback as you move into the third year on how you performed in the second year. When you do get to the third year of a new cost measure, at that point in time, that cost measure will be included in the cost category score for clinicians with eligible episodes or cases for that measure. So overall, an opportunity to really have an on-ramp to new cost measures and allow clinicians to adjust appropriately when they get applied. Moving on, we're going to look at the modification for cost category measures. Really is only the total per capita cost, or TPCC measure, where we see any changes to how the measure is calculated. So there's a few changes that are called out here related to how the triggering event is managed and exclusion criteria for the measure. So in 2025, the second visit can be either provided by the same clinician group or another clinician group. In 2026, the second visit can only be provided by the same clinician group. For event exclusion criteria, it requires in 2025 that only the first visit be provided by a clinician that isn't excluded based on specialty criteria. And in 2026, it requires both visits to be provided by a clinician that isn't excluded from the measure due to specialty exclusion criteria. And then based on the clinician exclusion criteria, NPs, PAs, certified clinical nurse specialists are included in TPCC. In 2026, those same provider types will be excluded from TPCC if they're part of a clinician group where all other clinicians are excluded based on specialty criteria. So this was something that impacted many specialty groups where the specialist providers weren't necessarily responsible for the total cost of care for Medicare beneficiaries, for all beneficiaries in the purview of the cost measures. But when they employed NPs or PAs, they had TPCC triggered and then were scored on that cost measure. So this is a change that's more appropriately attributing the total per capita cost to clinicians who are truly treating the total care for those patients. And I think for many of our specialty provider groups, this is going to be a benefit to truly achieving the goal of MVPs, as well as the measurement within cost categories of just aligning total per capita costs with the appropriate clinician groups. All right, so what does this mean for clinicians? No new measures for 2026. There's a reduction in the number of TPCC attributions. As mentioned, the PAs, NPs, and CCNs will be removed from being attributed due to clinician types no longer counted as primary care. And then a new structure for implementing new cost measures will eliminate the surprise attribution for clinicians and really provide a nice on-ramp for clinicians to get scored on new cost measures. All right, so moving on, I'm actually going to toss it back to Mike to cover promoting interoperability.
Great, thank you, Phil. Very good overview of those categories, and cost always being, everybody still thinks it's the newest category and most difficult, but it's been around for quite a bit now. So promoting interoperability, the key adds for this year that's no longer proposals, the security risk analysis, adding a second attestation, that requires a yes attestation. So not yet for implemented security measures. Basically, they're saying, okay, thank you very much for doing an assessment or an analysis of your security risks. However, what have you done to improve those risks? So for many years in this program, you could have turned in a security risk analysis that said, you know, we have all of these opportunities for risk and we're not doing anything about it. Now they're making you attest to the yes. So there'll be two yeses now saying that you actually are doing something for there. The safer guide, they are updating it from the 2016 version to the 2025 version. From an overall standpoint, from what I've read about the safer guide changes, it really has to do with modernizing the guide to 2025 standards, as well as the new programs, new language in the safer guide to update to the current state of healthcare. For TEFCO, which is the Trusted Exchange Framework and Common Agreement, they're adding an additional bonus measure to that. So there's another opportunity for you to score bonus points on PI. Establishing a measure for suppression policy, similar to the measure suppression policies for cost as well as quality. CMS is holding the rights to be able to say that these measures aren't needed in the final reporting due to various circumstances like changes in policy or things not being available, and such as the case with the suppressing the electronic case reporting measure backdating to 2025. That is the, what they're using for in the future to add the ability to suppress a measure. I don't see that happening often, but they wanted to cover their bases for being able to do this for the electronic case reporting for this year. So what does that mean when we're suppressing the electronic case reporting measure in 2025? So the issue is that the CDC has temporarily paused the ability for clinicians to report, register onboarding for new healthcare organizations. So the ability here is that basically you can't move forward in the program. And with this measure, what it is that you could only do option one or stage one, level one, whatever you want to call it, for the first year, right? And then you have to move into option two starting with your second year. Well, since it was made mandatory for 2024, 2025, a majority of clinicians would have to move to option two, and that validation process isn't available currently as they are making upgrades into the system. So their solution is that MIPS eligible clinicians will attest to either yes or no to meeting the requirements for either option one or two, or claim the applicable exclusion, and they will receive full credit for the measure. So that's a little change from what they said during the proposed rule, because they were just going to eliminate the measure as a whole, and they got a lot of feedback basically saying that the by getting rid of the measure, it was actually a negative impact on those that have been doing the work for it. So now everybody just gets the points as long as they attest to it. So what does this mean to clinicians? I think number one, the security risk analysis isn't a yes, I did it measure anymore. They want to take a look at what your steps are for improving. I do think that as time goes on, this will become more stringent as the increase in the number of fraud cases and so forth within healthcare and leaks of information has increased over the years. I think that they are going to want proof that you're taking the steps to avoid these things. And, this was the first year that I can remember reading the final rule where they really are emphasizing changes and improvements to the PI category. If you've heard these webinars in the past, I say like 3 or 4 years, there's been very, very few updates in PI compared to the other categories. But this year, as you can see, there was a little bit more action for PI. So I think that's going to become more and more important as we move forward in these programs. I'm going to throw it right back to Phil. We'll talk about MVPs.
All right, thanks, Mike. So now we're going to talk about MIPS Valley pathways. And as you should know, if you've been paying attention, MVPs are really the direction of the future that CMS is espousing, that they want clinicians to be evaluated on the specialty measure sets within the MVPs and cost measures, really to focus on the type of care that they're providing and get evaluated likewise. So the continued emphasis remains on a gradual transition and refinement of MVPs, and anticipates that MIPS in a traditional MIPS framework will go away by performance year 2029. There's still the possible introduction of core elements. Core elements was really spelled out in the proposed rule to look at selecting one quality measure from a subset of measures and having the remaining measures within an MVP list being required. So this would allow for further alignment of what measures get reported within an MVP by specialists. And that's still on the table. So that's proposed and will be finalized or not in future rulemaking. We also see a simplification and alignment of MVPs designed to help streamline the process, focusing on clinically cohesive measure sets, promoting team-based care, aligning with value-based care principles, and encouraging interoperability and digital measurement. So again, overall, we're really seeing the driving direction of MVPs as the main reporting framework for MIPS eligible participants moving forward. All right, so one of the differences as we look to the 2026 final rule is that CMS is defining the MVP definition, MVP participants more specifically, and breaking down specifically who is included in that definition. So we've got individual MIPS eligible clinicians, single specialty groups, multi-specialty groups that meet the requirements of a small practice, subgroups, and APM entities that are assessed on an MVP. So let's dive into that a little further. You go on to the next slide. So here's what changed and what brought about the definition of these MVP participants. So in the old methodology, CMS assigned specialty type based on the unique NPI and TIN combination, PCOS enrollment, and Medicare Part B claims. We're also looking at specialty groups defined as a group consisting of one specialty and a multi-specialty group considering of two or more specialties. What we saw is that this doesn't take into consideration clinician types like nurse practitioners and physician assistants, groups that provide care across multiple specialties but in one singular focus or clinical area, and then group dynamics like turnover, consolidation, acquisitions. So while it was really direct in just supporting multi-specialty and single specialty groups, it didn't allow for some of the nuances of the makeup of these groups. And as CMS transitions more providers or wants more providers to transition MVPs, they needed to be a little more specific in how that gets evaluated. So under the new methodology, groups will self-attest to their specialty composition during MVP registration, and this will allow them to define themselves as a single specialty group or multi-specialty group that meets the small practice requirement. So why is this happening? So large practices, as defined as 15 or greater than 15 clinicians, large multi-specialty groups have previously been defined as needing to break into subgroups in order to report MVPs. So that's been in the ruling. Large groups need to, or large multi-specialty groups would need to break into subgroups to report an MVP. But now CMS is allowing, I should actually, let me restate that, all multi-specialty groups have needed to break into subgroups in order to report an MVP. CMS is now allowing small practices to identify during the self-attestation process that they're a multi-specialty small practice group and allow them to do group reporting at the group level without breaking themselves into subgroups. Again, this is intended to allow a longer on-ramp to transition small practices into MVP submissions and participations, and allowing flexibility in how they are defining themselves. So back to our second or third point here, large multi-specialty groups do not need to self-attest because they're required to report an MVP as subgroups. They're attesting that they don't meet the requirements of a single specialty or small practice. So they still need to split into subgroups when they self-attest to reporting an MVP or registering as an MVP. The revised definition of a multi-specialty group to mean a group that consists of clinicians in 2 or more specialty types or clinicians involved in multiple foci of care, again, allowing for more flexibility in how multi-specialty groups can continue supporting the care types and performing the types of care that they are doing appropriately for their practices. It provides groups to be compared to peers that are providing care to similar populations. Always helpful to have more similar comparisons of performance, as that is the goal within the MVP framework. And it provides groups that employ clinician types like nurse practitioners and physician assistants to participate in MVPs that match their foci of care as well. Next slide. All right, so let's take a look at an example of a practice participating in MVP for 2026. So let's say we have a large multi-specialty practice. That practice can still break into multiple levels of MVP reporting. So that group can report traditional MIPS at the group level and continue to report as they may have in the past. That group can also break into individual reporting for traditional MIPS, looking at performance on an individual basis for your regular 6 measures and scoring methodology within traditional MIPS. That large multi-specialty group can then also report as subgroups for an MVP or multiple MVPs. So as mentioned, they are required to break into subgroups as opposed to reporting at the group level for a large multi-specialty group. So we see here in this example, in addition to the group and individual traditional MIPS reporting, this group is breaking into subgroups for each of their specialties to allow them to be evaluated on measures that are more relevant for their focus of care. All right, so next slide. So we also see some proposed changes or finalized changes to existing MVPs. You can see the MVPs listed out, and all MVPs saw the removal of 487, which was the screening for social drivers of health, that being removed. There's a number of QCDR measures being removed from MVPs as well. And then there are a few specific MVPs that had some more meaningful changes that we noticed in terms of available measures. I'll call out for all the dermatologists who are considering or have reported the dermatological care MVP, the removing of 130 removing of 130, removing of 2 QCDR measures, and then the addition of measures 47 and 238. So it's helpful to pay attention to those measures and how they might impact those clinicians there. We're also seeing in the gastroenterology care MVP removing of 185 and 487 as well, with the addition of 516. Just calling it out a few that we see as impactful here. And as we go into
Bill, also at the bottom there on gastro, they're actually adding a cost measure, which is abnormal to an MVP that's been around.
Yeah, good call out, Mike. Yeah, so that's going to be impactful with a new cost measure coming into play. Yeah, we really haven't seen too much of that. With the remaining inventory of MVPs, similarly, we're seeing 487 removed across the board. Just a few other, I would call out the neurological care, removing a number of quality measures, adding 513, musculoskeletal care, adding 134 and 182. And you can see for the other MVPs which measures are impacted. We also have the IA changes, didn't specifically go into those. And then we see another cost measure change here for the prevention and treatment of infectious disorders, including hepatitis C and HIV MVP. New for 2026, we are seeing the addition of 6 MVPs. Those include diagnostic radiology, interventional radiology, and neuropsychology. You can see the kind of description. I'm not going to go into those in detail. Also, the pathology, podiatry, and vascular surgery MVPs. So these are going to help broaden the scope of MVPs to include more specialty types. And we anticipate seeing the continued development of MVPs to capture additional specialties as CMS continues to push clinicians towards participation in MIPS value pathways. So what does this mean to clinicians? Choosing your specialty will be a benefit to multi-specialty groups that treat similar patient issues but have different specialty designations. So if you've already done MVP reporting, you'll just want to pay attention to your registration process, making sure you're aligning that registration with your makeup as a multi-specialty group. CMS is confirming that large multi-specialty groups will have to split their practices into subgroups for MVP reporting. Again, no group MVP reporting for large multi-specialty groups. And MVPs will continue to grow as they add 6 or more in 2026. But as we'll touch on in a moment here, keep a lookout for programs like ASM that are going to continue to further the focus on specialty reporting for quality payment program eligible clinicians. So that transitions us well into the new alternative payment model for 2026. Well, new in 2026, coming in 2027, that was in the proposed rule and is now finalized to start in 2027. So introducing ASM, or the ambulatory specialty model. So the ASM is a new alternative payment model, testing whether adjusting payment for specialists based on their performance would result in enhanced quality of care and reduced cost. So you can think of this as I mentioned, furthering the target of an MVP, but into a model that's going to specifically identify specialty areas and specific types of treatment, and evaluating those further with specific patient populations and targeted participants. So as a quick overview, this is going to be mandatory for select specialists. The CMS will identify who's included, and they have their methodology for choosing who's included. And then once selected, you will be required to participate in ASM. It's targeting high-cost Medicare patients with chronic conditions, and the model is starting with low back pain and heart failure as 2 cohorts of participants in its testing of this model and evaluation for expansion into future chronic conditions and models. This is driving competition between clinicians to reduce costs and improve quality of care, and it's covering 5 performance years. So as mentioned, it's starting 2027, so we'll see in 2026 the identification of who will be required to report, and that reporting or participation will begin in 2027 and going on through the end of 2031. And the model does include all MIPS categories. So how does it work? We're going to stay high level here because we are going to have future resources and webinars and blogs that cover ASM in more detail. But the model will incorporate patient-reported outcomes. So we talked a little bit about how process measures are still a part of the quality measure inventory. ASM will really focus on patient-reported outcomes for its evaluation of chronic conditions and care management around those. And it's going to attribute ownership of care to one clinician. This model is really evaluating individual clinicians and identifying those clinicians for participation, so you can really see a comparison of participation and performance and score on a one-to-one basis. In doing so, it's going to attempt to minimize the differentiation between a small and large practice, again, focusing on the individual clinician, and will have mandatory participation, including both high value and low value clinicians. and they will be evaluated on quality and episode cost. Next slide. So how are clinicians chosen? Again, individual clinicians only. CMS is looking at ambulatory setting based clinicians. And once you are eligible, you will be eligible for the duration of the model. As mentioned, there's two cohorts within ASM. There's heart failure and low back pain. Heart failure would include cardiologists, while the low back pain cohort will include a few different specialty types. Those are anesthesiology, interventional pain management, neurosurgery, orthopedic surgery, pain management, and physical medicine and rehabilitation. So a much broader set of clinician types that will be included. And FQHCs and RHCs will be excluded, or at least the individual clinicians within FQHCs and RHCs will be excluded from participation. CMS is looking at the bills claims under the Medicare physician fee schedule and the 10 NPI combinations and identifying clinicians for participation. It's also looking at those who meet the episode-based cost measure volume threshold for chronic condition, which is 20 episodes. And CMS is looking at selected geographical areas for how they select eligible clinicians for participation within the program. Next slide. So ASM participants will participate in a model that looks very much like an MVP. They'll be evaluated in the 4 MIPS categories, but unlike MVPs, ASM will require specific measures and activities eliminating choice. So as mentioned, this is kind of where MVPs are going, but taking that next step to specify exactly what clinicians are being evaluated on, so there's a more one-to-one comparison of their performance. Clinicians will be compared only to clinicians treating the same chronic conditions within ASM, and while they are participating, they will be exempt from MIPS. And as mentioned again, each NPI and TIN combination will be scored separately. So if there are clinicians participating across different TINs, ASM is just looking at unique NPI and TIN combinations. Again, we'll have a lot more information on ASM in future webinars and resources to share, but wanted to bring you that kind of preview of what's to come. And now I'm going to turn it back over to Mike to talk about MSSP.
Thank you very much, Phil. We've actually had some great questions come in too. I don't know if I'm going to get an opportunity to go over them at the end. However, I will be reaching back out to anybody that asked the question after the webinar if I don't get to it. So a couple of updates from the APP. So this is for your ACO reporting. There were 477 ACOs in 2024 that reported, covering 650,000 healthcare providers and over 11.2 million beneficiaries. The biggest changes are the definition of the beneficiary eligible for Medicare CQMs, as well as CMS confirming, I know this should be common to all of us at this point, but that Medicare CQMs and MIPS CQMs are identical, including their numerators, denominators, and exclusions. The removal of the health equity adjustment, which we've talked about, and policies from this final rule, CMS is saying that it will reduce spending by an additional $20 million over a 10-year period. All right, so the new beneficiary eligible for Medicare CQM. So this is the list that CMS provides you, that provides ACOs so who they need to report Medicare CQMs for. They have changed the requirement in backdating it retroactively to 2025, and now states that a Medicare patient who has at least one claim with a date of service during the measurement period from an ACO professional, and here's the change right here, who is a primary care physician or has one of the specialty designations, or who is a physician assistant, nurse practitioner, or clinical nurse specialist. Now, we'll explain that last part a little bit in more detail. Those physician assistants, nurse practitioners, or your CNSs have to have provided a primary care physician a primary care visit for them to count. So it's not just attributing to them like they did in the past. This will provide greater overlap with your assignable beneficiaries. It's going to help ACOs identify their eligible populations better, and it will be delivered on next quarter. So they are saying that the delivery of this beneficiary file should be at no later than the Q4 one that will be delivered in February. However, I do think that there is a chance that the one that's going to be delivered for Q3 sometime this month can already have those changes involved in them. Other changes for APP, I know I've said it a lot. The removal of the health equity adjustment bonus for 26. They were planning to remove it for 25. The only thing they actually did was remove the words health equity adjustment from the health equity adjustment bonus points. So they just keeping it as the words bonus points and got rid of health equity adjustment in 25. In 26, they eliminated the whole bonus opportunity. The caps for MIPS survey, so this is a big thing, even for MIPS providers that have to participate. It now needs to include the ability for people to do it based on be able to do these based on utilizing the web. That's an important aspect, as they have done tests to show that many more participants will be active with the CAPS for MIPS survey based on doing it through the web rather than from the phone and mail. Here's a list of the measures that are for the upcoming year. The only changes from the rule from last year is the elimination of measure 47. So no social determinants of health will be included on here. Once again, 2026, you can see we're adding the colorectal screening as well as measure 484 for group risk standardized hospital admission rates. And then next year, we'll be adding the initiation engagement of substance use disorder. And then in 2028, as long as they have come up with an ECQM version for the adult immunization status a year prior, then that will come into the APP plus quality measure set. This I'm definitely not going to dig into. This is exactly the same as years in the past. As you can see in 25, what you need to report on to meet the quality performance standard, then the options for the alternative quality performance standard, and then your ability to still participate but at a lower rate, and what ends up happening if you don't participate at all. In 2026, it's the addition of the additional ECQM to it. So that's what we were saying on the previous page, as well as the additional claims-based measure. This is the 2027 and 2028. The biggest changes here are that MIPS CQMs would be going away in 2027 calendar year for ACOs. So you won't see MIPS CQMs on here, but you do see that they are finalizing that the ECQMs, Medicare CQMs will be available moving forward. So what does this mean to clinicians? No major changes on reporting options and structure. The biggest change is in the breast cancer screening, which we were discussing. It's going to increase your population for the if you've been doing the ECQM in the past. The only major change is the removal of the health equity bonus and the removal of the social determinants of health for 2028. So a couple of interesting things I would like to go over, and then maybe I'll get a chance to answer a question or two, but we're introducing PRISM. This is our newest and the future of quality reporting. It's going to help you select measures, report, and see your score from many different angles, giving you the ability not only to look at things like traditional MIPS as you have in the past, but to understand what MVPs look like, subgroups, individual reporting, as well as future programs like the team and ASM program. Now gives you the ability to dump your data into one section with flexible tools to allow you to look at how your score will be from all different aspects. We also have, as cost becomes more important here, you can dig into your cost score utilizing our only one in the industry right now with being able to really dig into what your MIPS cost score is, what it's predicted to be at, as well as how you can make impact in those cost scores. So for more information, our sales number and email are right there to reach out if you're interested in learning more. Otherwise, please, feel free to reach out to us at any time and we'll hopefully be able to help you. So I'm going to go through a couple questions, and Phil, if you have any, pop in and feel free to jump on here. But the first one is, based on the change to the administrative claim measures and scoring curve, do you think this will cause CMS to increase the scoring threshold, which is currently at 75, in the future? Well, I thought that they would do this for the cost measures when they changed the curve, and they didn't. And as you saw in one of the first couple slides that we have, 87% of the people that reported MIPS in 2024 got an incentive. So I don't know if CMS is aligning any changes to their minimums to avoid the penalty if almost 90% of the people participating aren't getting a penalty. So may they change it in the future when the opportunities to make an incentive continue to stay the same? Yeah, they definitely can. But right now, I would assume that that 75 is not moving anytime in the near future. Um, Another one that we have here, we are a multi-specialty clinic with 10 specialties. How does moving to 10 subgroups reduce our burden? Uh, exactly, I get it, I understand. Now, as you even stated in a follow-up question, there will be measures that can go across all of the MVPs, but that really doesn't do much justice for you. The one things that I'll tell you, one, IA I think can be easy because there's a MVP IA measure that's across all platforms. The other thing I think that can be very beneficial to you as well is that we have you have the ability to self-attest for these. And when you self-attest for these measures, uh, for these programs, if your providers, while they may be multi-specialty, if they are seeing populations of patients around heart disease or something like that together, you can combine those specialties like cardiology and hematology or something like that, so that you have the opportunity to, not do 10. Maybe it's 6, maybe it's more or less, but definitely the ability to dig into that a little bit more and see where it stands. They did give a little bit of a leeway. It's not great though, but more we can discuss in the future as well. Um, what do you? When do you anticipate the new measure data will be available for view and health monics for 2026? Our system will have all of the ECQMs up in the system by January 1st. They're already created. And then as the year goes by, we will add all the specifications for all the CQMs. New measures do get a priority to get done, so they should be there really soon. However, CMS doesn't even release the specifications till late in December for all of the measures across the board. They let you know in the final rule some of the changes, but when it comes to codes and things like that, that doesn't happen till the end. One person asked difference between CQMs and ECQMs. We've done a couple of webinars on these, but CQMs are registry-based measures. They do not need to come from a certified EHR. ECQMs, while you can report them directly through a registry like our MIPS Pro/PRISM program that we have now, they need to come directly from a certified EHR system. All right, There's still a lot more questions. It is 2 o'clock here on the East Coast. So I'm going to wrap this up. I want to thank you very much, Phil, for joining me today. Way to come in and be the star coming in on last minute notice. Much appreciated. And thank you for everybody attending. Really appreciate what everybody's doing and being part of it. Have a wonderful, wonderful week. Thank you.
Thank you, everyone.
Thanks, Phil.